All right. So Dr. Cheryl Israeloff is known for treating patients' migraines and dizziness, and this lies in her special training to both diagnose and address eye misalignment conditions. She has more than 20 years of experience in practicing optometry and is dedicated to providing patients with relief and answers to their questions. We also have Dr. Marissa Zimmerman with us, and she is a graduate of Muhlenberg College with a Bachelor of Science in Chemistry, and she continued through to SUNY, the State College of Optometry, graduating Beta Sigma Kappa in 2013. She will actually be keeping an eye on the chat, so if anybody has any questions as we walk through our agenda and learn a little bit more about binocular vision dysfunction, she'll be keeping an eye on that to try to answer any questions that they are able to. But please keep in mind, Project Lyme is a nonprofit, and while Dr. Israeloff and Dr. Zimmerman are very qualified to speak on specific conditions, anything too specific, we're going to have to keep from not being answered, just given the rules we have to follow as a 501c3 organization. So thank you so much, Dr. Israeloff and Dr. Zimmerman, for joining us today. Really looking forward to learning a little bit more about this, and I'm sure many of the patients in our community feel the same. So I'll get started with Dr. Israeloff, which is the very basic introduction of what exactly is binocular vision dysfunction and how would you define it or diagnose it?
So binocular vision dysfunction is any problem with the way the two eyes are working together. That's simple and easy. You could have perfect vision with no glasses on out of one eye, perfect vision out of the other eye, you see 20/20, but you could still have a problem because we have two eyeballs and they have to work together, and then those images are then interpreted by the brain. So any problem with that, whether it's a vertical misalignment or a horizontal misalignment or spasming of the focusing systems because the two images aren't quite working on the same plane, can be a problem with your binocular system. A lot of times patients will say, I was told I have binocular. I said, well, everybody we hope is binocular. Not everybody is. If you only have vision out of one eye, you're monocular. So it's just simply a problem with the way the two eyes are working together. And to adequately diagnose what someone's problem is, we do a series of tests. It takes us a couple of hours. So we're really delving deep into how someone's eyes are working together and what happens when they look in different areas of gaze and what happens at different distances too, because that can matter.
That's really interesting. So it seems like based off what you're saying, you can have binocular vision dysfunction regardless of any other underlying conditions like a Lyme disease. However, Dr. Zimmerman, I'll swing this one over to you, is how can Lyme disease specifically impact an individual's vision and cause some of these symptoms?
Sure. So, a lot of times we don't know before the patient has Lyme disease whether they had an underlying binocular vision dysfunction. I don't think that Lyme disease actually causes it. I think just your whole system being so fatigued, it brings us out where they just can't compensate. Maybe they had a converging issue and then now their eyes just can't hold that fusion together. Definitely accommodation, that ability to increase focus and be able to sustain it and be able to relax it. I mean, that we've noticed a lot with our patients that have Lyme disease that we know beforehand, or even some of our patients, it takes a while for them to get stable and then they find out that they have the Lyme. Definitely a huge correlation there.
Yeah, there's definitely a lot of other overlapping systemic issues that Lyme disease patients face that can be impacted and compounded by Lyme. So it's not very surprising to hear that that really is the case. So Dr. Israeloff, I would move back to you in asking specifically what type of symptoms are you, I know there's an overarching like binocular vision dysfunction, but what are some examples of things that may identify to you that an individual may need to seek treatment for that?
So headaches are a huge problem. Headaches are probably one of the most, I think, in either, to me, Lyme affects people neurologically. So you get a lot of symptomatology, almost the same thing as someone who had a concussion or post-concussion syndrome, because it affects you neurologically. And vision is, the eyes are an extension of the brain. They're cranial nerves that control your eye movements. And then your vision is all interpreted through pathways in the brain. So you get a lot of these neurological type of symptoms. So the headaches are huge. Being dizzy with head motion is huge. Light sensitivity, sensitivity to screens and scrolling can be huge. Sound sensitivity we deal with. Even nausea, like nausea when you're doing certain tasks, can a lot of times be a sign of a binocular problem. If someone says, every time I go on my computer, I'm getting nauseous, that's like a big kind of red flag. That can be huge. Even anxiety sometimes can be caused by simply something going on with the eyes, because if someone's fusion, the way they're keeping those images too poor, every time they move their head, it gets split just a little bit. So they might not actually notice double vision, but we actually test for that, how good it is. And if it's kind of moving, you get these weird signals coming in through your brain. And so your body doesn't feel safe in space. And so then you start secreting stress hormones. So you have this terrible anxiety reaction in certain kind of conditions that people are like, oh, well, I guess I have anxiety disorder. But they're like, well, it's so weird. Why do I only have anxiety disorder when I'm driving my car or something like that? It's almost always visual. So it can cause like a whole host of symptoms that might not actually be connected to the eyes, especially the dizziness and anxiety. Yeah.
Yeah, that's extremely interesting. And I appreciate you mentioning just neurological symptoms in general, because science has shown that Lyme spirochetes have the ability to penetrate into the blood-brain barrier and impact further neurological symptoms. So I really appreciate you touching on all of those. And I had no idea about the anxiety. That's actually very interesting. And I'm sure several people in our community may be experiencing those specific symptoms. But now that we know a little bit more about what BVD is, I'm definitely curious to hear a little bit more about how your practice goes about actually treating individuals, what methods you may use to actually address these symptoms.
Well, first, when someone comes, we always let them know you're going to be here for the initial evaluation for a couple of hours. The history, someone's history is very important. And that, because we've actually had a few people that we've detected or have thought, by the way, have you been tested for Lyme? Because you're giving us some strange symptoms. One other symptom I want to, because I did have a case of this, and it's something called Ostelapsia, which it means moving images. So they get this aberrant feeling. It's not really real, but they feel the images are moving. And that was a case of a man, and it was Lyme disease that did that to him. So we spend a huge amount of time, first of all, just listening to the patient and getting their history. Then we analyze their gait to see how they're walking, how they're moving through space. We do a visual field test to make sure there's nothing wrong neurologically with the peripheral vision. Anything that we're concerned about that we might need to send somebody for other tests or scans, we do that. And then we have to start analyzing what happens with that person's fusion when they move their head back and forth. So one of my favorite tests is something called the red lens test. And we hold a red lens up in front of somebody's eye and one eye. And then you ask them, they're looking at a target in a very dark room, where by that test, we could see, are the images staying together? And then I ask them to move their head around. So I know when they're moving their head, what happens? Are they using both eyes? Does it split? Sometimes it's the first test I do. I'm like, I know it's wrong. Sometimes it's more tricky than that. And we use one of my favorite pieces of equipment is something called the Maddox rod. So that also separates, and we can then determine the image from the right eye, where that is in space compared to where the image in the left eye is. And again, we're measuring where that disparity is in the vertical direction and also the horizontal direction. And we're measuring that at different areas of gaze. Sometimes we have to start back at the base before we even do all those tests with just getting the right power on the person. So the images are clear and on the same page, because sometimes that is not, they're not corrected properly. And with that, all the other tests don't give us enough information. Sometimes we do the test without anything on, and then we're like, well, something's not right. We go back and we redo it. So the first evaluation can take a pretty long time. And then we analyze also that focusing system. How good is someone shifting their focus back and forth? It's called the accommodative system. And I think problems with that focusing system is huge in this population. Same as with the brain injury world. And we want to know how that person does shifting their focus back and forth, because people are doing that all day long because they're looking at a phone, looking up, looking at phone, looking up, looking at phone. So that problem, doing that, that's huge, big problem. So we want to analyze that to see if that's normal. And then, of course, we also, on top of everything, are also looking at the actual health of the eyeballs, right? Make sure the person doesn't, you don't want to miss glaucoma for dealing with all this stuff. So we still are looking at the actual health of the eyeball, the cornea, the retina, the lens, the pressure in the eye. We do all of that also. So the initial evaluation takes a while. You're here for a while, that first visit.
I would like to say too, most of the time when patients are either referred to us or decide to come here on their own, they are asked to fill out a questionnaire on our website. So based on the score that they get, I mean, now those questions have been, made to specifically, kind of weed out the people that probably don't have binocular vision dysfunction, and anybody really close to us, will get either a call from us or we'll email them, directly. But based on that score, we'll say, this definitely sounds like a high probability that they have binocular vision dysfunction, and no, they definitely should come here. Other than someone that scores low, maybe there's something else that's going on, and, possibly we could redirect them, somewhere else too.
Yeah, that's really, I have a couple follow-up questions for that, but I see one person, Leonard, has his hand up. I'm going to ask that if anybody has any questions for now, put them in the chat. And give Dr. Zimmerman the opportunity to read them over and respond to them either verbally or by messaging. We've definitely received a lot of questions from the community leading up to this event, and we want to make sure that we can hit on as many people as we possibly can. So thank you for being here. Thank you for raising your hand. Please type any questions in the chat for now. And we'll go ahead and jump back into with Dr. Zimmerman. Following up on that, with working with patients that you determine need to come to your practice and have binocular vision dysfunction, is there a standard timeline that you really work with a lot of patients? I know a lot of things are very given the individual situation, but is there a 5-year timeline, 10-year timeline to say we can get you back to normalcy?
I mean, everybody's a little bit different. At the initial evaluation, we see them. At the end of the exam, if we do find a binocular vision dysfunction, any prism that's needed to correct for that is trial frame. So the patient does walk around our office with that to see if they notice that improvement, just with the trial frame. I'd say most patients, definitely, notice an improvement, maybe only 20%. Once we actually put it into, glasses and everything's ground in, we have a pretty high, improvement, rate in terms of patient symptoms. Obviously, with underlying, health conditions, Lyme disease, patients that have had TBI, even uncontrolled, diabetes, blood sugar fluctuating, there's always someone that's not going to get 100% because there's other issues, that are going on. But when we do see them for that first evaluation, we see them back after they wear the glasses for about a month for what's called a progress assessment. So at that progress assessment, we remeasure and we do a lot of what we did in the first visit, not so much, dilating their eyes, but just remeasuring how their eyes work together now with the aligning lenses on. And based on that, we'll see if we have to tweak that prism power, at all. And if so, our lab's, very good. They're able to change that prescription out for the patient. And most of our patients, we really only see those 2 visits. Sometimes, we may see them 3 months after, but we usually get pretty good results within that first, 6-week period, with maybe possibly that second adjustment, which I'd say about 80% sometimes end up having.
Yeah. And after that time frame that we feel we have them stable, we'll get, on average a 75-80% reduction in symptoms, and then we see the patients annually, unless yearly, unless something else happens. My little caveat is, if someone has undiagnosed Lyme or it's not being treated, I've had a couple of cases that I just couldn't get the person stable. Their data, their number, I get them stable, I get them good, and 2 months later, they're all over the place again. And I've had a couple of cases, it was undiagnosed Lyme. Once they got treated properly, they were much better, less visually dependent. Really, their system really, maybe they still had a little bit of a problem, but they were really compensating much better, and they did much better. So it's always in the back of our heads, if we do have a person that, why are these numbers changing so much? Something else is going on that doesn't make sense. And so you have to think about it. You have to, delve into that.
Yeah, I'm actually really glad that you brought that up. Somebody just mentioned in the Q&A, is there something that can correct itself with treatment for infections? And it's like, you and I literally had this discussion very briefly when we checked in last night, is that yes, you have seen patients who, as they get treated for Lyme disease, some of their symptoms don't necessarily disappear, but they're lessened, just because, as you mentioned earlier on, Lyme can compound things because of the way that they overlap with the symptoms. So thank you so much for mentioning that.
Right.
And Juliana, I hope that helps. Leonardo, thank you so much for putting your question in the chat. I do want to ask it on your behalf, just because it's something that was just mentioned, is to either one of you, what is the cause for convergence insufficiency? Is that a sign of a visual misalignment? And can that be caused by myopia? I don't know what any of that means, but it seems like you might be able to answer on his behalf.
So convergence insufficiency is a form of a binocular vision dysfunction. So it's where the 2 eyes tend to be more relaxed out this way. So things come closer to you, you have a hard time converging on that target. So that's a horizontal misalignment that, definitely can be corrected with, prismatic lenses. In terms of, you said, what was the second question about myopia?
Can that be caused by myopia?
It definitely can. I mean, some people, just based on their prescription, it changes it. In terms of someone being myopic, nearsighted, they need a minus power to help to correct that. And minus actually helps to bring the images in. So it does actually help them, someone being myopic, other than the opposite of someone being farsighted and then having convergence insufficiency, they're having to work even harder through those lenses. So I wouldn't say there's always a correlation that just because you're myopic, that then you have convergence insufficiency, because that power does actually help a bit with that fusion.
Right. Myopia means you're nearsighted. Right. So, my actual thinking is that I wonder how many people are develop higher prescriptions, higher myopia, because they really had converging problems. And the human body was made that focusing system comes in to play when something comes closer, and you have to converge your eyes. And if you have a hard time converging and you're pulling that focusing system in too much, and then you can't relax it back out, you kind of get stuck in that near position, and you can get higher nearsighted prescriptions, just because you kind of got stuck because one system's kind of driving the other. So with Lyme or any kind of assault to the brain function, if you were predisposed to have convergence insufficiency, it's going to throw you over the edge. You're not going to compensate for it. And say you're a young person, maybe you would have started having that problem when you got older, you're going to start having that problem way sooner. It's the same thing, like I said, with someone who gets a concussion. I always tell them, well, the concussion didn't cause these numbers. You probably always had that. However, your body cannot handle that right? It's too exhausted, just can't do it. The muscles that control the eyes, converging in and out, diverging, just keeping those images together, they're the same kind of muscle that's in your biceps. So they get tired and they get fatigued. And I always tell people, people say, well, why I'm so much worse by the end of the day after spending, 12 hours on a computer. I said, well, it's like, you go to the gym and some days when you're just not feeling that well, that weight you usually fling around is like a brick to you. You're like, how come I can't do this? It's fatigue. And that happens a lot with these cases. And you need a tool to help you. You need a tool, especially in today's world. It is so visual. It is so visual in a way that I don't think the human body didn't evolve to do. We didn't evolve to sit on these screens like this. It's hard for a lot of people. You add something that's a neurological assault, and those people can be miserable.
Yeah, you speaking on a tool is a perfect segue back into the concept of treatment options. And actually what got us involved together in the first place is one of Project Lyme's board members, their son, you prescribed them prism glasses, and they said, you really got to get on this so we can educate our community a little bit more about what that can do. So could you provide a little bit more of a background of what are prism glasses and what makes them so unique to be able to treat BVD?
Sure.
So prism lenses, if people remember back to physics, what it does is it bends light. So in our world, what it really does is it moves an image. So we're not going in there doing any surgery and moving your eye, but we're moving the image to where your eye is seeing. So if one eye sees an image slightly higher than the other, we're moving that other image so that they're seeing on that same plane there. And then they're working more easily together. In terms of someone else, I did respond. They asked if you could do, vision therapy instead of the prismatic lenses for vertical misalignments. With vertical misalignments, it's almost near impossible to train one eye to come down and the other eye to come up. I mean, they work, together going up and down. One can't come this way and the other one going the opposite way. So we find, at times someone might have actually been diagnosed with convergence insufficiency, where they just honestly had this large vertical misalignment. So as things came closer to them, yeah, they couldn't converge. They saw double, but it was coming that their eyes just couldn't move diagonally because it just, we can't move our eyes in that direction.
Right. Sometimes we do, if we're doing any kind of therapy or exercises, we do it on a home basis. We give people things to do if they're dizzy with like gaze stabilization or tracking. Our firm belief is, a lot of people can go to a therapist's office, or even like it's the same thing again, like working out at the gym with your trainer. They go once a week and they don't do anything. It's not that once a week that does anything. It's what someone does every day. So sometimes we have people that because of their situation or what they needed to do for work or just their status, I needed to get them to learn how to just the control of converging and diverging, or just the tracking, which is really the only things I really believe that you can do exercises for. Sometimes we give that just so that person learns the control, desensitizes them. Again, I tell people you can go to a vision therapist. Yep, you could do 6 months of therapy. It'll take 4 months to start getting better. You stop doing it, and guess what? It all goes back. And this is from someone I was born with it, terrible convergence insufficiency. I was born with it. I have no vertical misalignment, completely horizontal. Did vision therapy heavy duty twice in my life. Don't do it anymore. Got prism in my glasses. And by the way, the prism, there are prism in these glasses. There are a lot of prism in her glasses. It doesn't look any different than other people's glasses. So
we
that's
don't
another
use the press
thing.
on that some people say, oh, I had a press on prism and
Nobody
it was all distorted. Everything's ground into the lens. It looks, completely like a normal lens.
Yeah. It looks like a normal lens. And we prescribe very small increments. Sometimes people just need a little bit of help. You don't have to have a very big misalignment, by the way, to have a lot of these symptoms, especially in someone with a neurological problem like Lyme, right? Because even just a little bit off can really make you feel sick. And so if people watching, all you have to do is just press on an eyelid, just a tiny bit of pressure, you'll see what happens right away. You're going to start doubling a little bit, and that can make you feel like, oh. So you don't need a lot of this alignment to have significant symptoms. And I think what's unique about us and our training is finding the small misalignments, the small. And I tell every patient when I'm initially evaluating them, little bits matter. So I want you to tell me a little bit. Well, it's pretty much little bits matter, because to a patient, especially a patient with a problem like Lyme disease, little bits matter a lot.
Yeah, you're definitely hitting all the main points that I know our community is looking to learn more about. One question in terms of symptoms that are from Lyme disease, but seem to have some overlap to the neurological issues that could be caused by BVD is it seems to me like brain fog, very similar with anxiety, really impacts how you're able to function throughout the day. Yeah. Does prism glasses have the ability to help calm some of these other symptoms of Lyme disease, or is it really just focus on the vision as well, specifically?
I'd say it really does. I mean, even patients that have, and some of the patients even in the panels today might have experienced like what's called visual snow, which, I mean, that is where you see almost like the old TV, that static that's on that. And, unfortunately that's, coming from the brain. So, I mean, it's nothing like we're trying to make your eyes see better to get rid of it, but we have utilized tints that help to calm that effect down so that it's not as noticeable. And sometimes by just doing that, or just giving them sharper, better vision, that their fusion, is easier than a lot of that brain fog, the dizziness, those symptoms that, resolve.
Yeah, a lot of times I feel like the brain fog also can come because they're using so much energy just to interpret what's going on in the world. So improving the visual input can definitely help lift a lot of those symptoms. What I must say it, 10 times a day to people, humans are visual. It's our primary sense. We learn so much of our world, taking where you are in space from your vision. So again, it's interesting to me that in the Lyme community, people say brain fog, and it's the exact same thing that people with concussion say. It is the exact same term they use, that brain fog. And so you see how just what happened to the neurological pathways and what are people like, how much energy people are using. And I think anything to make that stuff lift could be very helpful.
Yeah, that's so interesting that you mentioned a lot of those other symptoms, like I think you called it snow, something like it. We actually received several questions from our community leading up to this event that reference things like floaters, perception issues, feeling like in a haze. And one was saying that they had seen another ophthalmologist that essentially said what you said, which is a lot of it is overlapping with the brain and the fact that it's tired and it can cause a lot of those additional issues. So that's just crazy that you got a chance to discuss that topic before I even asked about it. And obviously it's something that's really impacting a lot of our community. But there was a specific question that I saw in the chat that I wanted to call out, that Andrea said she was CDC positive for Lyme in 2012 and has been treated multiple times, but she's recently started waking up with binocular Ocular, which lasts about 30 minutes every morning and is fine the rest of the day. Is this a common presentation that you might have seen, and what should she have it evaluated further, maybe next steps? And if this is too specific, I totally understand.
It sounds like she's waking up in the morning. It takes her a while to get going, and she's waking up with diplopia. That's double vision, and she's losing fusion. So she definitely, that's kind of the definition that she's got a problem with the two eyes working together. And it's either just her age, time, or again, her body just not fatigue. But so that is that intermittent double vision. It's not all day. Is super common. It's super common as people get older, and that stuff just you get more and more tired, those muscles are just getting too tired holding it together, it can get worse. So it's definitely something that I always feel you want to get ahead of, because you certainly, people get very nervous that there's something else wrong with them, and it can increase their anxiety so much when stuff like that happens. And you certainly don't want to be, you know, driving someplace and all of a sudden be like, what's going on? That happens, by the way, everybody just close one eye. Right, be safe, close one eye.
So like true, I should say true double vision should go away when you close one eye. If it doesn't, then it could be, you know, uncorrected astigmatism, or something else going on. But true double vision, definitely you close either eye, I mean, it should go away.
But yeah, that should definitely be investigated and treated.
Yes, we definitely encourage everybody to always seek the treatment of a medical doctor, a professional in the field. You know, as a nonprofit, we do our best to try to educate and have these great connections with Dr. Zimmerman and Dr. Israeloff. But at the end of the day, individuals need to go and actually, as much as they can, see a doctor and take treatment to try to get to a place of resolution where you can feel happier and healthier and live your life. But I saw a couple questions specifically related to a thing called uveitis. Uveitis. Okay. I had a couple people ask things like, are there protocols to heal this specifically for Lyme disease, which it seems like based off of what you've been talking about so far is there's nothing specific to Lyme, but more specific to the eyes, but definitely curious to hear a little bit more about the condition and how it may apply to BVD and how it may apply to your practice specifically.
So uveitis really comes from, I mean, inflammation. So uveitis could come just idiopathic. Most percentage of people get it just for no reason at all.
It's no reason.
Yeah, but most of the time I'd say, definitely no reason. The other causes, we would send someone for blood work to test for like Lyme disease, rheumatoid arthritis. There's some other, uncommon kind of autoimmune Crohn's disease, these BCLA, types of conditions. So usually we'd send them to rheumatologists for all of that. In terms of the treatment, it's, unfortunately, most of the time, like a steroid eye drop, sometimes they have to be on oral steroids. It is something that you have to be followed very closely, because if you wean off those steroids too quickly, you can get a rebound inflammation there. There's usually not really too much of correlation with binocular vision dysfunction at all. Yes, maybe it's going to make your eye, not see as well. Most of the time it does reduce a little bit of that vision and clarity, but it's not really affecting how the two eyes are working together.
Right, but it can be quite painful.
Right.
So
very painful. Yeah, very like light
to the light, and that would come on more acutely. Yeah. That's like
a very red eye, painful eye.
That's an inflammatory reaction. And yeah, that is something that, we definitely, when you see that, if somebody presents with uveitis, you're gonna start investigating why, especially if it's, it happens more than once. You want to know. So, but I don't think I agree. There's no real correlation with binocular vision dysfunction, other than it could also be a problem with anybody who has an inflammatory condition. And so these conditions that cause these overlapping neurological and inflammatory, I think the neurological aspect is kind of more of Lyme is more important for the binocular vision dysfunction. So when we say we check the health of the eyeball, the uveitis stuff is more of those individual eyeballs and the health of it. But uveitis is pretty like an acute thing. We're going to know if someone has that. You could see it in the eye.
Yeah, that makes a lot of sense. Dr. Zimmerman, I see you just put in the chat, vision specialist of Michigan. Could you describe a little bit more what people can learn from that, and then maybe share a little bit more about where your practice is at, and if anybody on this might be able to rely on you.
Right, of course. We're located in Garden City, New York, so we're about like 45 minutes outside of Manhattan. There are, a bunch of trains that do come by very, close to where we're located, or someone could take the train, even Uber from there, or there's, buses too that do come, close by. So where Dr. Cheryl was trained was by Dr. Debbie Feinberg at Vision Specialists of Michigan. and then Dr. Cheryl then trains me. And anybody who lives outside of, the New York area, I mean, we do see patients from all over. I know with COVID now, patients aren't traveling as much, but if they do go on that vision specialist website, it will say like search for a provider, and you could put in your zip code and find if someone, has been trained and closer to you. But our practice and her practice in Michigan are actually the only two practices that just do the binocular vision dysfunction full time. Other practices have kind of implemented into their, regular primary care practice, but we're Monday through Friday, 5 days a week, we see, binocular vision dysfunction patients.
And we need to kind of separate ourselves from behavioral optometrists, or we're specifically called neurovisual optometrists. And we practice something called neurovisual medicine. It's kind of unique how we were trained. We have unique testing and tools that were all developed by Dr. Feinberg. So that's what makes us, our approach to solving these problems, quite unique. And we see patients from all over the place. So people are traveling again. I have someone from Virginia tomorrow.
Right.
So people are traveling.
Someone from Romania.
Before COVID, we had quite a few European patients. So that's not really unusual in our world. But because it is very unique what we do. So there are a few other people scattered in the country that were trained by Dr. Feinberg. But we do this full time, and so do their practice. So it's a good resource for people.
Yeah, I was actually on a panel earlier today discussing patient interaction in a digital world, but it seems like based on the type of tests and everything that you have to run is not something that you would be able to do telehealth appointments or anything like that. That's understand. I mean, I'm sure a couple people in the chat are sad to hear that, but I completely understand the needs for this is a very physical type of diagnosis. So thanks for all of that additional information. And I will make sure, I always send around a video and a couple links afterwards to everybody who registered. So Dr. Zimmerman or Dr. Israeloff, I have to get that website from you so that I'll be able to share it with everybody who registered. So with about 10 to 15 minutes left, what I want to go ahead and do is give you the opportunity to actually share maybe one or two success stories of patients that may have been really tough coming in and that through your treatment have left better off than they were to begin with. If you, maybe we'll start with you, Dr. Israeloff, if you have any examples that come to mind.
I always have 20 examples that come to mind. So this one woman, young woman, her mom was a patient of mine who had significant problems that no one could fix, and then it just became, as she got older, it was like intermittent double vision, and so that's how this girl found me. She said, I think I got stuff going on with my eyes. And she's actually the example of someone that was tough. I couldn't get stable. She worked at a computer all day. We had very different data with different tasks. So how she performed at 20 feet and 8 feet, and then up close, she was really having at the intermediate was a big problem. And when I first saw her, it's like we needed 3 different prescriptions in different areas just to get her some relief, stable. And I would get her stable. She was also a farsighted person. So she was really having, so many of her problems was that focusing system just not working properly. It was like, okay, yes, you have a lot of binocular issues, really similar to your mom's, but why is your focusing system like, she was 20, was like, in the 20, she's like 20 something years old, and her focusing system's acting like a 52-year-old. So I said something else has to be, and sure enough, it was undiagnosed Lyme. She also was having some joint pain and stuff like that. So she finally got treatment, and it took a while for that to get stable. She came back, and now she's like, I think I'm doing better. So it went, then I needed 3 different pairs of glasses for all these different tasks she had to do, down to 1. I was able to remove, she was so sensitive to screen. I had different filters on it just to relax her, which she was able to function with that, but it just kept changing all the time. Down to 1 and functioning beautifully. So really just now down to seeing her, once a year, which is, that's more typical. But that was a case of undiagnosed Lyme causing that instability, right? Other people, if it's the opposite way, we already know, then if there is that underlying binocular problem, as soon as you identify it, you fix it. Had one case of someone that was, off just a little bit in the vertical, pretty significant, horizontal, had a really hard time keeping it converged because they just kept going like this. It was getting that vertical. Once you lock the vertical part in, you give them a little help with that. I tell some people sometimes I'm just giving you a tool to give your system a little kick in the pants. Boom. Now they're where they were like 10 minutes on their computer, they were getting a headache. Now they're like, I'm 6 hours and I'm good. And I would say that's kind of our typical patient.
Yeah, I had someone else too that first time I saw her probably about 2 years ago, actually had Lyme testing done. And because I had asked just based on how her symptoms were, and she said, oh, it was negative. I mean, MRIs, MRAs, VNG, like vestibular testing, ENTs, rheumatologists, they had diagnosed her with like Raynaud's. Then she went to a neurologist and we diagnosed her with migraines, actually put her on Topamax, which is a very strong migraine medication, which we call like Dopamax. It makes you a little bit loopy and can make you feel even dizzier on top of that. And when she saw me, definitely, I mean, her focusing system for sure was, affected. She did have this vertical misalignment. And just in the office, when I trial framed, that little bit of a refractive power, she had a little astigmatism with that vertical prism. Immediately, she said her headache was like 100% better. She said her dizziness had gone down at least 50%. I did use a tint because she was very light sensitive and worked with a lot of like fluorescent lighting. And I saw her probably about like 2 months later. And she said overall, she was about 60 to 70% better. I actually told her to go back to the neurologist to see if she could kind of wean off the Topamax, since there was such a huge improvement just in 5 minutes with sitting with the lenses on. So by the time I saw her again, she was weaned off of it. And we do have some supplements that we recommend to patients that have, research done that have helped with migraines that have actually compared it to Topamax. So she had started those. And she was doing real well. And I saw her last year. She had moved to another state and had actually seen a doctor there and was diagnosed then with Lyme disease. So, I mean, she's going through more like different like herbal treatments now, but she's doing, I mean, really well. I mean, she's back to work where she wasn't even able to work as well as she was before.
That's so I want to speak to both of those stories because they really hit what Project Lyme's community is all about. And first, I'll talk about Dr. Israelov. The fact that your patient was so young and then diagnosed with Lyme disease, that's something that we actually see a lot and is worrying as a part of our awareness and education efforts, that the largest growing population of people diagnosed with Lyme disease is that demographic of like 15 to 35. And we actually have an initiative called Generation Lyme for all of those in the audience right now. That is a group of people who all have Lyme disease who meet on a weekly basis as kind of like a support group to work through the diagnosis process, the treatment process, and ideally your journey to recovery. So I'll drop that website in the chat as well, but just a lot of people in that age group that we're seeing being afflicted. And then to Dr. Zimmerman's point, the fact that you were able to wean off of what is quote unquote traditional medicine to treat a lot or to treat some of those symptoms with glasses and supplements is really something that I know a lot of people in our community are interested in doing, because the standard approach is just throw a lot of antibiotics at it and hope that something works. And the way that you're able to, through your guys' practice, address symptoms in a non-traditional way and really work people back to functionally being able to live day in and day out, especially as Lyme patients who are not necessarily able to go outside as often as they would like to. So they're forced to use screens much more than maybe they would traditionally want to. The fact that it all kind of wraps in together with the way that you both treat patients, I think is really great. So thank you so much for spending some time with us today. I'm going to, like I mentioned, drop those two websites, that's projectlyme.org and genlyme.org, into the chat. And then I will also bring up your guys. What is your website again? I had a link to it.
It's NVC, N is in Nancy, V is in Victor, C is in cat, of NY.com, Neurovisual Center of New York.
For those of you interested in checking more of Dr. Israeloff and Dr. Zimmerman's practice, thank you again so much to both of you for spending some time with us today, providing so much great information to our community. As you can see, there's still a lot more questions that are in the chat, but it's definitely tough to get to everybody. So I appreciate all the questions that were put in. What I'm going to do is get a list together, and ideally somebody from our Project Lyme team will try to get you some answers as best we can. And we do this after every event. And then just keep in mind, we'll be sending around the video to everybody in case there's something that you need to revisit that you may have not been able to catch on right away, because I know we moved through a lot of information in the past 45 minutes. So again, thank you so much to the both of you. And thank you to all of our attendees today. Everybody have a great rest of your evening. Keep a lookout for more events, educational events from Project Lyme.
Thank you.
Thank you. Thanks for having us.
Yeah, thank you. Bye-bye.